Welcome to another PrecisCa tumor board. Great to have a world-renowned faculty to discuss these cases. I'm Dr. Benjamin Levy. I'm an associate professor at Johns Hopkins School of Medicine and a thoracic medical oncologist. And again, joined by a wonderful group of faculty. I'm going to allow them to introduce themselves. We'll start with Dr. Bala.
I'm Sanjeev Bala. I run the cardiothoracic imaging section here at Washington University in St. Louis. It's good to be here.
My name's Wally Curran. I'm the Chief Medical Officer globally for Genesis Care and Professor and Director Emeritus of the Winship Cancer Institute of Emory University.
I'm Varun Puri. I'm a thoracic surgeon and professor of surgery at the Washington University in St. Louis, along with Dr. Bala.
I'm Ross Camage. I'm the Director of Thoracic Oncology at the University of Colorado. I'm a medical oncologist and delighted to be here again.
78-year-old female, former smoker with a diagnosis of stage 4 adenocarcinoma, bilateral lungs with MET amplification and a PD-L1 of 100%. Other mutations are negative. What would you recommend for first-line therapy? So patient presents with a chronic cough and shortness of breath, performance status ECOG 1, medical history consistent with hypertension and Crohn's, social history of former smoker, 40-pack year history with no alcohol or drug use, and no family history of malignancy. So this is the CT chest. I'll let Dr. Bala review this.
So the CT with both the lung windows and soft tissue windows, and interestingly, they've used intravenous contrast, which is, as you know, variable based on institution, but it shows nicely this 6-centimeter lesion in the upper lobe on the right with this central area of low attenuation, which presumably is necrosis. And in the right paratracheal space, we can see that there's some soft tissue attenuation, which is in keeping with this kind of infiltration of the mass into the mediastinum.
Okay. Thank you for that interpretation. And then the PET scan?
And the PET scan confirms, and you can see again this uptake along the periphery of that area of necrosis. There's both right paratracheal and left paratracheal lymphadenopathy, left hilar lymphadenopathy, and there's this right supraclavicular lymph node, which could easily be missed if there weren't for the FDG, as well as some pulmonary nodules. So we're dealing with lymphadenopathy, as well as this central necrotic lesion with this uptake along the periphery.
Okay, at least based on PET scan, looks like with the multiple pulmonary nodules bilaterally stage 4 disease. So patient appropriately has a brain MRI that's negative, seen by medical oncology and started on capmatinib I just want to go back and make sure that I haven't seen the tissue biopsy, but it says here in the summary, MET amplification and a PD-L1 of 100%. I don't see along the case here where that biopsy was done, but the patient, based on having MET amplification, we can certainly lean on one of the world authorities for MET amplification here today with Dr. Camage about the role of starting capmatinib 400 twice a day. This is what the patient got, or excuse me, 400 twice daily, tolerated the therapy well. Question, what would be the recommended first-line therapy? So Dr. Camage, MET amplification, we've got MET IHC, we've got MET amplification, we've got MET copy number, we've got MET exon 14 skipping mutations. There's a lot of confusion here on this pathway and the appropriate biomarker to select for the appropriate therapy. Give it to us, distill it down to us, the complexity and what you would do here.
Well, so the MET pathway can be turned on in a number of different ways, including an increased copy number of the gene, which would be covered under the umbrella of MET amplification. The issue is, unlike an EGFR mutation or an ALK gene rearrangement, which are categorical variables, gene copy number variation is a continuous variable. So the devil is in the details. Exactly how was the testing done and what was the level? So yes, there are a proportion of people who truly have very high levels of MET amplification where it is the primary driver of their cancer. And yes, those patients tend to be older and they can have a significant smoking history. So they resemble to some extent the MET exon 14 skip mutants who also have MET as their primary driver. And there is some overlap between the two. Sure, the patient here appears to be tolerating it, but before I tell you that capmatinib was absolutely the right choice for them, I'd really like to know how they defined MET amplification, what level, and what else did they look for. So So the answer is maybe this was absolutely the right thing to do, or maybe it was completely the wrong thing to do.
Other therapies other than capmatinib, crizotinib, would that be a consideration prior to the approval of capmatinib? Or if, second question, if the MET amplification is real, is that your go-to? Again, I know the devil's in the details, but if it's true and it's real, is capmatinib your first choice for your patient?
So let me flesh that out a little bit. So when we're talking about high-level MET amplification, which by FISH analysis is usually described as a ratio relative to centromere of chromosome 7 of 4 or greater, by next-generation sequencing assays, which don't quite all do the same thing. There's a little bit of black box in the bioinformatics, but generally speaking, they tend to call a gene copy number of 6 or greater. There we are seeing about a 40% response rate, so looking very similar to the MET exon 14 skip mutations. When you have ratios of 2 or copy number of 3 or 4, I don't know that that's real. So yes, if you have high levels, you're going to treat it a bit like a MET exon 14 skip mutant. You're going to use capmatinib or tepotinib or crizotinib. You're also going to have at the back of the cupboard those other MET-directed therapies that I talked about, some of the MET antibody drug conjugates in clinical trials, other MET antibodies in clinical trials, and then you keep chemotherapy in reserve. Now, here, you might want to give chemo IO, but remember the patient has Crohn's disease, so this might be a situation where you might be using chemotherapy alone.
Okay, so quick case here, but it sounds like if the MET amplification is real, 4 or greater by FISH, 6 or greater by gene copy number on NGS, that would be a consideration to use capmatinib first. And if we are going to think about IO or IO in combination with chemo, certainly be mindful of the patient's Crohn's disease.